Welcome back, listeners, and welcome back, Stu. My guest today is Dr. Stuart Gitlow. He is a partner and chief medical officer at Limitless Ventures, as well as the past president of the American Society of Addiction Medicine. And he also has an active private practice as a psychiatrist in addiction medicine. Stu was a previous podcast guest, and if you have not listened to that episode titled History and the Elimination of the Data Waiver, I suggest that you go back and listen to it. Stu provided some great insight into the history of the data waiver and methadone clinics. Before we jump in today's topic, which is the new ruling from the Biden administration allowing buprenorphine prescribing through telemedicine, I want to ask you, Stu, about something that we talked about in the last podcast. You are in favor, are in favor of eliminating the data waiver for provider prescribing, and you commented that it was a good thing, but we'll see how many physicians take advantage of that prescribing, or providers, I should say, not just physicians. Is it too soon to tell? Have you seen people taking advantage of that?
I have not, and it may be too early to tell. In fact, I was in a conference call earlier today where some of the folks on the call still were unaware that a data waiver is no longer required. So
Yeah.
that information has been well circulated, but it still hasn't made it to everyone, I think. So that's part of the issue. The other part of the issue is that pretty much everybody who wanted to treat this population went ahead and got the data waiver. It wasn't as if there was any major obstacle besides some regulatory paperwork. There wasn't an enormous requirement of expense or anything along those lines. Some educational CME were required, but as physicians, we're required to get that every year in one area or another. It could just as well have been this area. So I think the folks who wanted to prescribe it were, and the folks who weren't prescribing it didn't want to. And that's, I think, where we are now. It's just the regulatory paperwork has been lessened. That's great. But I'm not expecting a huge uptick in number of people prescribing the medication.
Yeah, that's an interesting point. I mean, we get focused on, oh, we got to open it up, make it easier so we can get more prescribers. But you're right. It wasn't that it was that onerous to begin with. And so if they wanted to do it, so I guess it's a different message to get out there, right? Is that in your private practice, whatever your private practice may be, you're going to encounter people that may have a substance use disorder, and it may not be completely obvious to you unless you ask and are proactive, and then you can perhaps make a difference.
Yeah, in some ways, and I think this will get into or segue into the conversation that we're going to have, but I think the perception about buprenorphine is that it is a mysterious medication that differs from all other medications in some exceptional manner, and therefore needs to be considered differently than one would consider other medications. All medications are unique in their own special way, but insulin, aspirin, Prozac. These are three very different medications used for very different reasons. And yet all of them are understood by a majority of physicians out there who can utilize them as necessary. Suboxone, buprenorphine, for whatever reason, isn't thought of that way.
Yeah.
It's thought of as somehow being exceptional, different from the pack, something that maybe I only want to prescribe if I'm special in some way.
Yeah.
And I think that's the obstacle that we need to overcome. I think this new regulation is one of the steps that was necessary to get there.
Yeah. Well, the data waiver may have precipitated that perception, right? It's like, well, wait a minute. I can
Right.
prescribe all these other things that have all of these side effects and all of these interactions with other drugs, and yet I can't do this one. So it must be
Right,
like
right, and
extra.
of course, the fact was under the data waiver that I could prescribe as much OxyContin as I wanted to, as much Xanax as I wanted to, but for Suboxone, I was watched. Right, we were all being
Right.
audited, we were all being monitored, as if Suboxone was more dangerous, more exceptional than these other
Right.
drugs that could potentially cause harm.
Right. Interesting. That kind of takes us back to a little bit of the history on how that all unfolded. Okay, so the data waiver's been lifted, opening more for physicians, prescribers, providers to prescribe. And now they can prescribe via telehealth. Telehealth obviously took off during COVID. It was one of those things that had big changes during that time. In our previous podcast, you mentioned you did transition to seeing patients virtually. And did you find them as effective as in person visits? Pros, cons there? Let's start there with just telemedicine in general.
So I think people understand the basic concept of churn in any business. Churn is the process by which excuse me, process by which you lose customers and then obtain new ones. The rate at which customers churn in a business model is something that's usually monitored, and it would indicate, if there's a high level of it, that you're not doing a good job keeping your customers.
Mhm.
We have the same thing, the same type of model in a private practice medical office where we appreciate the fact that a patient keeps coming back, is doing well, feels comfortable with the doctor, feels comfortable with the office, it comes in on a regular basis, and is therefore not replaced with a new patient, and there's no new opening. So churn should be low in a general or psychiatric practice. That's a good thing. What we noticed during the transition from in office practice to telemedicine for our Suboxone patients specifically was that churn dropped amazingly to zero. Um, from the start of the pandemic until the point where we returned to in-office treatment, we didn't lose a single one of our Suboxone patients. And as we looked back to see what had happened originally, we would lose patients, but generally it was from their ability or inability to come to the office. They lost their mode of transportation. They no longer had a working car. They couldn't afford the gas money to go back and forth to the office. Whatever it was generally around logistics rather than some issue with the clinic. So our um, our reaction to going to an online modality was that the system worked better from the patient's perspective. Now, that raises an issue, and it raises the obvious question of, well, maybe it was just working because these patients, were pulling the wool over our eyes. They really didn't need to be on Suboxone. They just said they did, and they were more than happy to continue to see us with a lessened degree of intensity than they had had previously. But in other respects, we had more input with the online ability than we had before. For instance, I could see the individual's home. I could even ask, show me around. Let's see where you live. Let's see what the place
Mhm.
is like. And it says a lot for somebody if they're doing well that their house is neat, the kitchen is clean, there's no dishes in the sink, things like that that
Mhm.
you can spot in a teleconference that you'd never have a clue about in person. So there were pros and cons to it, but in general it worked quite well.
Okay. And yours were virtual. You could see them always, or did you do audio only too?
In general, once we had patients who had been seen on a regular basis for years, especially those that we knew already from the office visits, we would allow an audio only visit from time to time. Sure.
Okay. All right. When we spoke last, you touched on this new ruling that we're going to talk about. Obviously, these things take time, and so it was in the works. And what struck me as interesting when I read the ruling is that it would allow providers who have not had an in person visit with the patient to prescribe 6 months worth of buprenorphine through telehealth, including audio only visits. And then after 6 months, the patient would need an in-person or another form, I don't know what that means, of telemedicine visit to continue. So break it down for us a little bit and share your thoughts on that ruling.
So Suboxone is scheduled in a manner that allows a physician to write a prescription for up to 1 month at a time with up to five additional refills. It's not like, for instance, the stimulants for attention deficit disorder, where I can only write for 1 month of a stimulant, and then the patient has to come back and be seen again before I can write for a second month and so forth. Um, but buprenorphine can be written for up to 6 months. And again, that also differs from standard medications, let's say like Prozac, which we could write for a 90-day supply with three additional refills. So a patient can get a 1 year supply when they're seen at the office. So Suboxone falls somewhere in the middle. And in general, well, no one's going to get a 6 month prescription when they're seen initially, because the first thing you want to do is have some confidence that the medication has worked, that the person is responsive to this dosage or that dosage, and that they are, in fact, doing better on the medication. So you might only give a few weeks the first time, or you might give a month the first time, but then want them to come back for sure to see what to do next. However, certainly if I have a patient who's transitioning to me from another office and I have their medical record showing that they've been on Suboxone at a stable dose for an extended period of time, and let's say they've just moved to the area, and I get their old medical record, and I'm confident in the accuracy of that record, and now I see the patient, whether by telemedicine or by phone call or whatever, and discuss it with them, and they are ready to move on and be seen by me on a regular basis for their very stable opioid use disorder, that's stable on a given dose of the Suboxone. Might I, at that point, write a prescription for 1 month plus five refills? Sure, that's possible. Particularly if all of the data line up and it's clear what the patient has. So I think what we're doing is trying to make it reasonable. I don't think the government intends for us to do that typically. That wouldn't be the standard, that you would just simply start everybody with a 6 month supply and say, all right, I'll see you in half a year. But there are certainly many cases where someone's transitioning from one doctor to another or one prescriber to another, and that would be reasonable.
Okay, that makes sense. Now, when I read through the ruling, I didn't see anything about, you talked about the history and if there's an established history. I didn't see anything that makes it that that's what it has to be, the case. Okay, so somebody could theoretically go to a physician, never have met them, audio only. I want treatment. What are your thoughts on that?
Well, we've gone from you have to have a special dispensation in order to be able to do this. The patient has to come in person. You have to do a physical exam. To yeah, we really don't need any of that, and you can give it for as long as you'd like. So there's probably a middle ground. The pendulum swung all the way in the other direction. In truth, I think it's important to lay eyes on the person. I think it's important to, if not see them in person, then at least see their surroundings and have a video. So I think that's an important part. I don't think a hands-on physical exam is necessary. And that's always been true from a psychiatric perspective,
Sure.
that we do a mental status exam as our hands-on physical, and that's representative and standard of care for psychiatry. But so I don't think we need to do a blood pressure. I don't think we need to do vital signs. But if we're looking for track marks, it's nice if we can see their arms. But again, that's something they can share with us through the video feed, and
Mhm.
that's something that we can see how they look, and
Right.
get a feeling for that. Um, the old school of thought was, in order to give buprenorphine, somebody had to be in withdrawal. Um, and,
Mhm.
and so you had to look for signs and symptoms of withdrawal. But people often have other reasons that are quite reasonable. A patient might come in, for instance, and say, I used to have a problem with opioid use disorder. I go to meetings. I am regularly at 12 step. I haven't used in 3 years, but I'm going through a divorce. It's a difficult time. I'm not feeling like as safe as I want to. I feel like I might pick up. Is there a way that I could take a medication that would be safe for me to take that would make it less likely for me to do that? And that's a very reasonable time to put somebody on a low dose of Suboxone as a method of adding some degree of safety to their situation. But of course, there's no way of proving their story.
I
I
was
have
just gonna ask that. It's like, how do you like? I mean, psychiatry fascinates me anyway because I feel like and this is, I'm sure, just ignorance on my part, but it's like, I think I could fool you, like if you're trying to, but you know what you're doing and you probably know a lot of the tactics. So, yeah, how do you verify somebody's story?
we know the tactics, but we're also not lie detectors, and our job isn't that, right? The job is to do what all doctors do, which is do no harm while reducing risk. So in that particular scenario, one of the things I have to think about is how risky would it be to give this person Suboxone at a low dose if they're not telling me the truth?
Hmm.
And the fact is that it's not particularly risky.
Hmm.
So I'm weighing that against how important is it for me to give Suboxone to this person if they are telling me the truth?
Right.
And in that case, that would be sort of important.
Yeah, but would it be fair to say that if they're not telling you the truth, then they're probably wanting it for somebody else or to make money off of?
Either one is a possibility. Whenever you have restrictions on a product, its street value goes up.
Hmm.
So my expectation has been that with the lessening of restrictions, the ease of obtaining a prescription, street value would go down. And the likelihood of somebody coming in and asking for a medication specifically so they can resell it is lower as a result.
Hmm.
Um,
Yeah.
I don't know whether that in fact is the case or not, but I've seen very little abuse of Suboxone. What I have seen is use of Suboxone by individuals not under medical care because they couldn't find a doctor who would prescribe it. So most of the people who have come to me over the years for Suboxone treatment for opioid use disorder were already on Suboxone when they walked in.
Okay. Yeah. I guess I could think of a couple of things. One would be the stigma. I
Mhm.
I just can't bring myself to sit in front of somebody and tell them. And so I have, a willing partner that's going to do it for me, or maybe insurance issues, right? My sister, my mother, my spouse, they have insurance and it would cover it and they can do it telemedicine and it gets charged to their, but then I get the medication. Those
Sure,
are two things. Yeah.
and that way it also doesn't somehow become knowledge by my workplace.
True.
Maybe I do some work where it wouldn't be
Security clearance.
right, wouldn't be a good thing. Uh,
Yeah.
so, yeah, all of those issues come into play, just like they would with other medications. If it was difficult to obtain insulin at a
Mhm.
doctor's office, you would expect insulin to have a street value.
Mhm. Mhm. True. Although, I mean, I think with those when it's a mental health issue, like you said, you don't need that physical exam, so it's harder to prove, right? If I'm going into the doctor's office because I have insurance and I'm saying I have diabetes, but I'm giving the insulin to someone in my family, doctor's going to be wise to this,
Right,
pretty quickly, or they
right,
should be anyway.
right. And
So it would be harder.
you're giving the reasonable argument, right? It is all of these things are always possible.
Yeah.
Somebody could be lying to us. Somebody could be reselling the medication. Somebody might take half of what I prescribe and sell the rest.
Mhm.
And they really do need it, and it really is something useful to them. But they found that they could take only a smaller dose than what's prescribed and make some money on the side paying their costs of coming to see me. So,
Mhm.
um, you know, all of those things are possible. But again, my job is not to figure out the patient's economic wherewithal, but rather to assess the degree of medical risk versus potential medical benefit.
Mhm.
That's the job. Others, certainly law enforcement look at us from time to time and say, "Well, you should be trying to reduce diversion." Okay. And we are, by weighing the medical risk against the medical benefit.
Mhm.
But I don't go out and specifically look to see if somebody is selling their medication or using only half of it or
Right.
stockpiling it. Because if I look for it, then what I'm doing is I'm taking my patient, whom I have an agreement with, that I'm going to treat them like a physician, that I am going to accept them at their word, and acting more like a police detective.
Mhm. Mhm.
That's not my role here. My role is physician. Now, on the other hand, if you lie to me and I discover the lie, well, then you've broken the contract. And that's a point where we can work on that as an issue going forward.
Right. Yeah. And it is important, the relationship in your line of work, the relationship you have with your patients is very much built on that trust and feeling comfortable with you. And if they think that you're, being judge and jury and police at the same time, I could see how that would kind of impact the relationship. And we have to assume that most physicians will do the right thing when they get a new patient that has no history. It's not all about, well, I can do this and this is easy. Um, so most
Right.
physicians will do the right thing on that.
Yeah, and I think certainly one could see many of these folks. The big problem that we've got is that only a small percentage of patients with opioid use disorder are actually in treatment. If all of them came to treatment, we wouldn't have sufficient prescribing power, right? There wouldn't be enough docs out there to handle that.
Right.
So if you get one facility that says, we're going to specialize in this, we're going to see nothing but patients with opioid use disorder. Um, well, then suddenly hundreds of patients with opioid use disorder would show up and they'd say, how can we do this more efficiently during this period of an epidemic where there are an insufficient
Mhm.
number of treating clinicians out there?
Sure.
And so one of the things that they might do would be and if use different efficiency models. One of which could be we're going to give the patient 6-month prescriptions,
Yeah.
and that way we're reaching the most patients that we possibly can. They're getting the treatment that is first line treatment for them, but the risk of diversion goes up because of the way we're prescribing.
Mhm.
Is that worth it? And that's a public question rather than a doctor question. And at this point, given the way the pendulum has swung, it looks as though the public said, yes, that's worth it. We'd rather have a little bit more diversion so that more of these patients are able to obtain treatment.
Right. Yeah. Well, and hopefully in offices maybe it could be integrated. Here's your 6 months worth, but let's touch base, even if it's not the physician that is touching base, but some case management type of person that, checks in with them on a semi-regular basis just to keep their finger on the pulse.
Sure, and there are a number of apps that can be used. I met with a company this morning that's working on an app that the patients can use on their smartphone that
Mhm.
allow them to interact with the physician on a regular basis through the month,
Mhm.
so that the doctor has essentially constant input with how the patient is doing, uh,
Right.
and then can reach out to the patient if need be during the course of the month if a problem arises. And those sorts of abilities are going to increase in availability as time passes, and I think make the entire process easier. I think back, and once you're over 50, you start thinking back a lot. And yeah, at 60 now, I remember as a kid, um, you know, not only would the pediatrician come to our house if there was something wrong with me, but we could call him and 7 days a week, 24 hours a day. He'd answer the phone. We'd have a discussion. I remember my mom talking to him, late one night, and he would come over if he needed to. And that system worked well until our population grew. And there was just no way of accomplishing that anymore for the numbers of people who need fairly rigorous care. But we need to move away from the you can't reach your doctor,
Yeah.
no way, no how, without going through voicemail and messages and three administrators and different phone numbers, and you never quite get the doctor.
Right.
Yeah, that system doesn't work.
Yeah.
And I've always given my patients my cell phone number, and they call when they need to call. It actually doesn't end up being a significant burden, and I wish more docs would still do that because it really works okay.
Yeah.
But again, that what we want to do through technology is make it so that the patient and the doctor can actually interact, even if it's only briefly, because that means a lot to the patient to know I can
Right.
reach my doctor anytime.
Right. Yeah. And there's monitoring apps too. I can't remember the name of it. I should have, well, if I had known we were going to have this conversation, I would have refreshed my memory, but where you can see their vitals and different types of behavior that might alert you to, oh, there might be a problem that is starting, or their stress levels that have changed, their sleep habits that have changed, and then alert the office to reach out to them proactively.
Right.
Yeah. Okay. For pharmacists filling these prescriptions with this on this new regulation, they are required to verify the identity of the patient receiving the prescription, which I'm sure happens with the controlled substances in general anyway. So that may not really be much of a change for what pharmacists have to do, but that was included in the regulation, the stipulations.
Yeah, the pharmacies are in a somewhat difficult place. The pharmacies are required to consider the accuracy of a prescription that
Mm-hmm.
they're receiving. And in fact, the Department of Justice has chased after both CVS and Walgreens, as well as a number of other
Mm-hmm.
pharmacies, on this issue, claiming that the big pharmacy chains have been filling prescriptions for opioids, which are fraudulent.
Mm-hmm.
And that the pharmacies should have known they were fraudulent based on a number of indicators that the DOJ calls red flags. The problem is that red flags often aren't really red. So, for instance, with Suboxone, one of the so called red flags is patients travel a long distance in order to obtain their prescription. Or they receive a prescription from a doctor who is located a long distance from their home.
Mm-hmm.
Perhaps that's a better way of putting it with telemedicine. And then the pharmacy gets it, and there is the red flag, right? There's this doctor who patients seem to be traveling long distances to go to. Well, of
Mm-hmm.
course, with Suboxone, there are very few doctors who prescribe it. And the only doctor who's available might indeed be a long distance from their home. Um, Another so called red flag is multiple patients from the same family are seeing the physician and obtaining the same care. Well, of course, addictive disease runs in families. And if you're an individual who's a member of a family where multiple people have addictive disease, isn't it easier if you all go see the same doctor?
Yeah.
So again, not a red flag. It's something that we see pretty typically in the addiction field. But the pharmacies are watching for things like that and then saying, we won't fill the prescription because there are too many red flags. And it's not our fault. The DOJ has indicted us on this exact thing. So
Mm-hmm.
what are we supposed to do? And I feel for them. The pharmacists, are really caught in the middle of this. And I know some doctors where specific pharmacies won't fill their prescriptions. Um,
Mm-hmm.
and, then the doctor tells the patients, you need to go only to pharmacy XYZ and not pharmacy ABC. And that, of course, is also a red flag for the DOJ. So,
Yeah.
so
Whoa, look at all these prescriptions they're filling because nobody else will fill them.
exactly. And so it's an awful
It
situation where
is.
where law enforcement and the provider community haven't been on the same side. We need to get on the same side.
Yeah, it can look like one thing, but it's really something different. And each case is individual, and you can't just, throw it in a bucket. And it is difficult. A little bit of an interesting story is I no longer, but used to live in California, and you may be familiar with the regulations in
Mm,
California are, very, very regulated,
right.
more so than some states, but certainly, DEA also covers California. But I was spending a little time in an independent pharmacy doing some work for them so that their owner slash lead pharmacist could have some days off. And first, their handling of controlled substances was just like, what, very free, very free. It's like,
Hmm.
well, that's the way we do it. It's like,
Right.
okay, well, not when I'm here. You're not going to do it like that, right? And then there were a couple of times that a prescription came in and it didn't sit well with me. So I got on the phone and I called the physician's office, to
Hmm.
have a conversation. But let's just say I didn't stay there very long. They stopped asking me to do shifts, and I won't name their name, right? It's like, okay, one of these days you guys might be in trouble because you are just so free with what you're doing that, something's going to end up happening. But it is difficult to, you're the patient's waiting. You've got to get the physician on the phone. You have to have that conversation and, kind of hash out like, what's going on here? And do you know that they're here? And did you sign this prescription? Right.
Right. Right. Yeah. I'll share a story. There was a pharmacy some years ago where they had called up to confirm a prescription. Massachusetts had a law at the time, I think they still do, that required pharmacists to confirm the accuracy and some otherwise verify the prescription. And a lot of them interpreted that as requiring them to call the doctor. So they would call me. And what it meant in reality was that on a day when our office was specifically seeing, Suboxone patients, we would get dozens and dozens of
Oh,
phone calls from
wow.
pharmacies. Anyway, like I said before, I'm always perfectly happy to give my cell phone number to my patients. Well, my cell phone number is also printed on the prescription blank.
Mhm.
So when the pharmacy called, it would come directly to my line. I'd answer it. The pharmacies would very frequently just hang up when I answered the phone. And I would see that it came from a phone number that I knew was at a pharmacy, and I'd call the pharmacy back. I said, "Why did you just call me and hang up?"
Mhm.
He said, "Well, you answered the phone. Doctors don't answer the phone. It obviously meant you're not a doctor. And this is a fake prescription."
You're like, no, if it was a forgery, the ring would be smarter than that.
Right, right, why would I do that? I'd send it to voicemail. So
Oh my
no,
goodness.
I said, "Go ahead and Google me, look me up, look at my picture, and that's me, and I'll answer whatever questions you want, but I answer my own
Wow.
phone." Um,
Wow. They
so
just assumed.
they assume
Interesting.
they assume that if the person is answering the phone, that it's obviously a fake.
Yeah. Yeah. Well, it's true. Not very often would the physician answer the phone.
Right.
But to assume that, yeah, interesting.
Yeah,
Wow.
but again, it's one of these tricky things, as
Yeah.
you asked me originally, is the patient telling the truth? Well, the
Right.
pharmacist has to ask the question, is the doctor telling
Doctor
the
telling the
truth?
truth because I can't see you. I'm just on the phone with you. You could be
Right,
anybody.
right, right. And
Yeah.
it's awful because really, you know, you remember the TV show House, where Dr. House would
Mhm.
say, patients
Mhm.
lie.
Yeah.
And of course, we're aware that people aren't always forthcoming with us. We know that.
Mhm.
That's sort of the starting point. Um, but you do have to assume, if somebody walks into a psychiatry office, there's genuinely something wrong. I'm not trying to blame the victim here.
Yeah.
My goal is to figure out what that is and to
Mhm.
make sure I'm treating the right thing. But to an extent, that is largely based on what the patient tells me.
Sure.
And so long as they are telling me things that are untrue, I'll eventually figure it out because there'll be an inconsistency.
Mhm.
And
Mhm.
the importance of that rises only if I have to prescribe something potentially dangerous.
Okay.
Suboxone isn't potentially dangerous, no more than aspirin or anything else. I
Yeah.
mean, can you take too much? Sure, but it's really unlikely to cause massive harm.
Right. Okay, that makes sense. What are your thoughts on emergency rooms starting treatment? I mean, I think the risk there is, I mean, it's great if a patient comes in and express the desire and you can get them started, but then they've got to coordinate. And maybe this whole telemedicine thing will open that avenue up to allow that further treatment. But have you seen EDs doing that? And what are your thoughts on that practice?
I have. I think it's wonderful that they address that. The downside is there is some potential risk. Let's say I'm at an ER and I give somebody 2 weeks worth of Suboxone. I say, okay, you now have 2 weeks to go see a doctor. Here are names of doctors in the community who would continue this. And the patient takes the Suboxone and then stops at the 2 week point when they run out. And they have not yet seen another physician.
Mhm.
And they pick up heroin or fentanyl and take their usual dose. Well,
Mhm.
now their tolerance is gone because they've been on a medication for several weeks. And when they take their old dose, that's an overdose
Mhm.
because they can no longer tolerate the dose that they used to tolerate. So there are some risks with it that come along unless you know you can set up that appointment. So my suggestion would be yes, prescribe it in the ER, but do so in coordination with an outpatient appointment that you set up right then and there.
Right.
So the patient at least has a known appointment that will make it so that they never run out.
Right. Yeah. Yeah, that makes sense. And that requires more coordination in a busy ED, but the right thing to do if you really want to have success in the program.
Right.
Yeah.
Right. And certainly it's possible if the hospital has an outpatient clinic where Suboxone is being prescribed,
Perfect.
then it should be easy. We just do it on the computer and it's all set at the point that you
Right.
leave. So that would be one way of dealing with it.
Right. That would be perfect. Okay, yeah, that makes sense. All right. Any other words of wisdom that you'd like to put out there for providers, pharmacists, anybody related to this topic?
I think the only thing important is that we do need to get together the law enforcement side along with the medical community and the patient community to make sure everybody's on the same page. I
Mhm.
think there's been so much stigma around addictive disease in general, Suboxone specifically, that it's become something where a lot of people are still hands off. And we need to solve that and openly solve it, make it clear it's actually been solved,
Mhm.
to make it so that there aren't docs still staying away from the medication. On the other side of it, it's that the addiction epidemic isn't just opioid use disorder, it's addiction in general.
Mhm.
And I think what people don't realize, and maybe this is our next discussion, is that by increasing availability to other addictive drugs, such as cannabis, that we're increasing the likelihood of an individual having addictive disease, and therefore increasing the overall burden on society that wouldn't be there otherwise.
Yeah, no, that's a good point. And my kids would joke with me. I don't know how much they were joking or not joking, but oh ha ha ha, mom, marijuana is a gateway drug. Anything can be,
Sure.
as I meet more and more people, anything can be. And for many, it was marijuana.
Right.
Um, so yeah, that can be a problem.
Yeah, it's sort of odd that at the same time that we're going through every possible way that we can to stem the methamphetamine crisis or the opiate crisis,
Mhm.
on the other side of the coin, we're doing as much as we can to increase the availability of cannabis.
There, that's right.
And great, people will go from one drug to another drug, and this time it might be, the opiates that are the gateway drug, and they end up with cannabis, which for 80% of the people isn't going to be a problem, right? Most people can use cannabis just like they could use opiates and not have an issue.
Right.
It's the minority that we're concerned with, the 15 or so, 20% who will use it and end up apathetic, unproductive, overdosing, whatever the issue is going to be.
Yeah.
They just won't live up to their potential. And that's what we're trying to avoid.
Right. That's right. If you have that propensity for addiction, it doesn't anything will be your gateway drug, right?
Exactly.
It starts there.
Exactly. Well, thanks
Yeah.
very much for having me on again.
Thank you. Thank you very much, Stu.
You're
This was
welcome. Good
great.
seeing you.